Hi friends, once again welcome back to the Nurse channel, and as you all know that we have started a series to crack the upcoming AIIMS NORCET and the JIPMER examination. So this video also contains some 16 important, very important questions, and the peculiarity of this video is that we have selected questions which are ICU based and emergency medicine based. Okay, so these questions not only will help for the AIIMS NORCET examination but also for any interview, ICU related interview also. Okay, so once again welcome you all back to our channel, and I request everyone who are not subscribed our channel, kindly subscribe and support us. And so straight away we'll move on to the questions.
So moving on to the very first question in the ICU interview series, and here is the first question for you. The question is: peak paracetamol toxicity presents how long after ingestion? So you can expect cases in the emergency department where drug poisoning cases can come. So the question is: peak paracetamol toxicity presents how long after ingestion? And the options for you are: option number A, 3 to 5 days, option number B, 6 to 12 hours, option number C, 24 to 72 hours, and option number D, within 30 minutes. So you know that paracetamol is an easily available drug which will be there in every households. So the chances of toxicity are also high with paracetamol. So you should understand how long after the ingestion of the paracetamol toxicity the peak presentations can happen. So what is the answer? So the answer for this question is option number C, that is 24 to 72 hours. So in this explanation session, we will be understanding how much paracetamol can be given in a daily basis. Okay, so first of all, we will see even after the ingestion of a potentially fatal dose, there are rarely and initial signs and symptoms in a paracetamol overdose. But if there is toxicity, that toxicity builds with early signs of liver damage present from 24 to 72 hours. So this is the answer for our question. So 24 to 72 hours. Okay, so we should understand how much is the recommended dose of paracetamol. That means acetaminophen for the adult is 650 milligram to 1000 milligram every 4 to 6 hours. Okay, so 650 milligram to 1000 milligram every 4 to 6 hours, not to exceed 4 grams per day. So the maximum recommended dosage is 4 grams per day. So what about children? In children the dosage is 15 milligram per kilogram every 6 hours up to 60 milligram per kilogram per day. Okay, so maximum is 60 milligram per kg per day. Okay, and when toxicity develops, the toxicity will develop at 7.5 gram per day to 10 gram per day or 40 milligram per kilogram per day. Okay, so this is a toxicity value. Okay, so I think from this question you are getting information regarding the peak toxicity presentation time, then recommended dose for the adult, children, and a toxicity dose. Okay, so I think that question was very useful for you. Now we will move on to the next question, that is the second question in this series, and the question is: which among the following is an antiplatelet? Okay, this is another confusing question and it was a regularly asking question. Which among the following is an antiplatelet? So the options for you are: option number A, streptokinase, option number B, morphine sulfate, option number C, heparin, and option number D, aspirin. So which among the following is an antiplatelet? So what is the answer? So you know that the answer for this question is obviously option number D, that is aspirin is an antiplatelet. Okay, so what are the other options? What about the other options that we will see? We know that an antiplatelet drug, also known as the platelet agglutination inhibitor or platelet aggregation inhibitor. Okay, so antiplatelets can be also called as platelet agglutination inhibitor or platelet aggregation inhibitor, and it is a member of a class of pharmaceuticals that decrease the platelet aggregation and inhibit the thrombus formation. Okay, so their function is to decrease the aggregation of platelet and thereby inhibiting the thrombus formation, and the examples are well known: aspirin, then clopidogrel, etc. Okay, so this is antiplatelet. Then the other options we will see. So thrombotic agents or the thrombolytic agents or the thrombolysis, also known as the fibrinolytic therapy, is the breakdown of the blood clots formed in the blood vessels using the medication, and the medications which are used as a thrombolytic agents are streptokinase, urokinase, etc. Okay, So you know the importance of this drug in MA and all. Okay, so thrombolysis means it's a lysis, that is fibrinolytic therapy. That means it break down the blood clots formed in the blood vessels. Streptokinase, urokinase. Then another option was regarding the anticoagulant, because heparin was another option. So heparin is an anticoagulant commonly known as the blood thinners. Okay, these are the chemical substances that prevent or reduce the coagulation of the blood and prolonging the clotting time. Okay, so it will prolong the clotting time and it will reduce the coagulation of the blood. Okay, so examples are heparin, warfarin, etc. Okay, so another option was regarding the morphine sulfate. So you know that morphine, it is a pain medication belonging to the opiate family, which is found naturally in the opium. Okay, so the importance of morphine sulfate in the MI management and its importance are also very important, that you can refer later, and we have already discussed in our old videos. Okay, so we will move on to the third question in our series. That is a very important question, and the question is, what does fast in stroke stand for? Okay, so in the emergency department you can expect stroke patients. So what is fast in stroke stand for? So the options for you are fingers, arms, stomach, toes. Option number B, fast acting stroke thrombolysis. Option number C, face, arms, speech, time. And option number D, first aid in stroke treatment. So what is a fast in stroke stands for? So that's a question, can be asked in the interviews also. So the answer for this question is option number C, that is face, arms, speech and time. Okay, so now we know that FAST, it is an acronym which is used as a mnemonic to help detect and enhance responsiveness to the needs of a person having a stroke. So what does this acronym means? This acronym stands for F for the facial drooping. Okay, the stroke patients can be presented with one-sided facial drooping, or there will be facial paralysis. So facial drooping, then arm weakness. Okay, any limb weakness will be there. That will be that A stands for this arm weakness. Then S stands for the speech difficulties. Okay, speech difficulties. And the time, what is the time? That is the time to call the emergency services. That the time we have to bring the patient to the emergency department for the treatment. Okay, so this is the fast means facial drooping, arm weakness, speech difficulties and time. Okay, so I think that also was very useful for you. Now we will move on to the next question in this ICU series, and the question is, which among the following electrolyte imbalance can aggravate the digitalis toxicity? Okay, so the question is, which among the following electrolyte imbalance can aggravate digitalis toxicity? So this is also a frequently asking important question. So the options for you are option number A, hyperkalemia, option number B, hypokalemia, option number C, hypermagnesemia, and option number D, hypocalcemia. Okay, so what is the answer? So in this explanation session, I will be explaining about the other electrolyte imbalances that can also aggravate the digitalis toxicity. So you know the answer for this question, that is option number B, that is hypokalemia can aggravate digitalis toxicity. How that will be explaining in the explanation session. So we know that electrolyte disturbances such as hypomagnesemia, hypercalcemia and hypokalemia lead to increased sensitivity to digoxin, making toxicity more likely even with a lower concentration of serum digoxin. Okay, so from this question you should learn about the that serum digoxin level, therapeutic serum digoxin level and all that we can refer later. So these are the electrolyte imbalances that can aggravate digitalis toxicity. So hypomagnesemia, hypercalcemia, hypokalemia. And next I am going to explain how hypokalemia will result in digoxin toxicity. So digoxin toxicity is worsened by hypokalemia because digoxin binds to the potassium K+ site of the sodium potassium ATPase pump. So sodium potassium pump, it will be affecting the sodium potassium pump. How means this digoxin will bind to the potassium site. So conversely, what will happen? Hyperkalemia will minimize the digoxin's effectiveness. Okay, if there is hyperkalemia, then digoxin, whatever digoxin we are giving, that effectiveness also will be less. Okay, so this is related to the sodium potassium ATP pump. Okay, so the another reason is that the renal excretion rate of the digoxin is markedly reduced markedly reduced during the hypokalemia. Okay, so if there is a hypokalemia, there will be renal excretion rate of the digoxin will be reduced. As a result, there will be accumulation of digoxin in the serum and can lead to risk of digitalis intoxication. Okay, so this is another reason. Okay, so first one is the sodium potassium ATP is pumped, and the second one is the renal excretion of the digoxin because of hypokalemia. Okay, I think that is clear for you now. Now we will move on to the next question in our series, and another important question: which statement is false regarding the defibrillator? Okay, so which statement is false regarding the defibrillator? So the options are: option number A, biphasic defib uses lesser joule, lesser energy. Option number B, monophasic defibrillator needs to charge at 360 joules. Then option number C, this defibrillator delivers synchronous counter shock. Then option number D, defibrillation indicated in pulseless ventricular tachycardia. So which statement is false regarding defibrillator? So just go through the options. So think about the monophasic and biphasic defibrillators. Then what is defibrillator and where it is indicated? Okay, so what is the answer? So the false statement in this question is option number C, that is it delivers synchronous countershock. So that synchronous countershock means that is cardioversion, not defibrillation. Okay, so we will have a small explanation regarding this question. So synchronized means it will be cardioversion and it delivers a low energy shock to the heart, whereas during the defibrillation a high energy shock will be delivered without the need to time the shock to the unstable rhythm. Okay, so the cardioversion, it is a planned procedure, it is an elective procedure, and it is a synchronized electric shock will be given, but in the case of defibrillator, it is a high energy shock will be given to the unstable rhythm. Okay, so that is a wrong statement. Then we should understand about the monophasic and the biphasic defibrillators. So a monophasic waveform delivers electrical shocks in a single direction from one electrode to another. Okay, so mono means single, so it will be delivering the electric shocks in a single direction from one electrode to another. And with a biphasic shock, the current travels in two phases. Bi means two phases. Okay, so monophasic defibrillator, it gives a single 360 joule shock. Okay, monophasic means single 360 joule shock, and the same energy does on the subsequent shocks. Okay, so that is the monophasic. It requires a higher energy shocks. Okay, but in case of biphasic waveforms, it requires only less energy and have slightly risk than the monophasic defibrillation. Okay, so what is the risk? That is the skin burn chances, then the over electric shock chances. All these things are very less with biphasic forms. Okay, so that's why the most preferred technology for the new automatic electric defibrillators, okay, these AEDs are biphasic, not monophasic. Okay, so I think you are getting a small information regarding biphasic and monophasic and how much energy should be used in each type of defibrillators. Okay, so I think that question also is finishing now, and I think that also was very much helpful for you. Now we will move on to the next question, and it's a picture based question, and you can see a picture in the screen, and the task is to identify the picture. Okay, so what is this that you have to identify? So the options for you are: option number A, central venous catheter; option B, dialysis catheter; option number C, peripheral intravenous catheter; and option number D, midline peripheral catheter. Okay, so what is this catheter? Identify this catheter. So in ICUs, you can see patients with this catheter, so you can easily answer this question. So the answer for this question is option number A, that is a central venous catheter. Okay, this is a central venous catheter. So we know that this central venous catheter, so this is the picture where a central venous catheter is inserted, and you can see the central venous catheter, otherwise known as a C line or the central venous line or the central venous axis catheter. It is a catheter placed into a large vein. Okay, into a large vein, and these catheters are commonly placed placed in the veins in the neck, that means internal jugular vein, then over the chest, that means subclavian vein or the axillary vein, or in the groin, that is the femoral vein. Okay, so these are the three main areas where we can place the central line, that is the subclavian vein, internal jugular vein, axillary vein, or in the femoral vein. Or sometimes we can through the veins in the arms, which is also known as a peripherally inserted central line. Okay, peripherally inserted central line, or through the arms we can guide this towards the one of the largest vein in the body. Okay, so this is the central venous catheter, and this is the catheter which is placed in a vein. Okay, so now we will see the other options what I have given in the question. So what is this catheter? What is this catheter? Can you identify this catheter? So this catheter is called as a dialysis catheter. Okay, so this dialysis catheter, you can see that it contains two lumens. Okay, one is a venous lumen and the another is the arterial lumen. Okay, so you know that why we have to go for dialysis and all that you can refer later. So this, although the both lumens are in the veins, this will be connected, this will be inserted into a vein. The arterial lumen means, like the natural arteries, it carries the blood away from the heart, while the venous lumen returns the blood towards the heart. Okay, so this may confuse. We are just inserting the tip of this lumen into the vein only, and through the arterial part we will be taking away the blood, and from the venous part we will be infusing the blood back. Okay, so that is the purpose of these two lumens, and in detail you can refer it later. Okay, so this is the dialysis catheter. Now the another option was regarding the peripheral venous catheter. That is the simple our cannulas or the PVCs or the peripheral venous line or the peripheral venous axis catheter or the peripheral intravenous catheter. So it is a catheter that is a small with flexible tube which is placed into a peripheral vein or the venous axis, for the venous axis, to administer intravenous therapy such as medications, fluids, etc. Okay, so this is our simple cannula, that is a peripheral venous catheter. Then another option was the midline catheter. So what is a midline catheter? So this is a picture of the midline catheter, and this is the picture of the midline catheter when it was inserted into the body. So you can see that the end of the catheter is not reaching the main vessel. Okay, this is the main vein, so it is not reaching the main vein. So before that it is getting entered. Okay, so midline catheters, they are inserted into the antecubital or the other upper arm vein, and they are typically 20 centimeters long. So the length of the midline catheter will be 20 centimeter, and the tips do not reach the central veins of the thorax. Okay, so it won't reach the central veins of the thorax, it will end in the midway. So that's why it's known as the midline ID catheters, which is of 20 centimeters long. So I think that also is clear for you. So with a single picture based information, you are getting information regarding the another three important catheters which are used in the ICU setups. Okay, now we will move on to the seventh question in our series. It's regarding the neurosurgical emergency, and the question is, which among the following neurosurgical emergencies requires priority care? Okay, so the question, you should be very careful, you should read very carefully, because here the question is asking regarding which neurosurgical emergency requires priority care. Okay, so the options for your option number A, subdural hematoma; option number B, extradural hematoma; option number C, subarachnoid hematoma; and option number D, spinal cord compressions. So among these, which neurosurgical emergency requires primary care or the priority care? So you know that all these are emergency neurosurgical emergencies. So in this, which one requires priority care? That's a question for you. And what is the answer? So the answer for this question is obviously option number B, that is extradural hematoma. Why? That we will be explaining in the explanation session. So we know that epidural or the extradural hematoma is when there is a bleeding occurs between the tough outer membrane covering of the brain, that is the dura mater, and the skull. So between the skull and the dura mater is the toughest covering, and this epidural hematomas, this epidural bleeding will be of arterial injury or the arterial cause or arterial break. So usually middle meningeal artery will be there, then there will be certain development of the hematoma will be there, and as a result, you know that herniation and other complications can happen very fast. So we have a set of guidelines to prioritize these neurosurgical emergencies that we will see now. So the acute extradural hematoma are categorized as an immediate life-threatening event. Okay, so the first category is the immediate life-threatening event, and it should be intervened within 15 minutes for better outcomes. Okay, so within 15 minutes we have to intervene for acute EDH cases which are categorized under immediate life-threatening event. Okay, immediate life-threatening event. Okay, so The next, like subdural hematomas, intracerebral hematomas, penetrating injuries, and post-operative deteriorations, and these are categorized under the life-threatening category. Okay, the old one was the immediate life-threatening event, and this is the life-threatening category, and it should be intervened within 1 hour. So the first category is the immediate life-threatening category, the second one is the life-threatening category, and this has to be intervened within 1 hour, and it includes subdural, intracerebral hematomas, then penetrating injuries and postoperative deteriorations. Then comes the next category, that is the spinal cord compressions by trauma or tumors, then coda equina, intracranial tumors which causes critical raised intracranial pressure, skull fractures, etc., or the block shunt. These are considered as the organ threatening events, and it should be intervened within 4 hours. Okay, so these are categorized under the organ threatening events. Okay, organ threatening, life threatening, immediate life threatening. Okay, so I think that is clear for you. So with this question, we are getting information regarding the how to categorize the neurosurgical emergencies. Okay, so EDH comes first. Okay, so I think that is clear for you. Now we will move on to the 8th question in our series, and this is from the obstetrical emergency, and the question is postpartum pituitary gland necrosis is also known as. So the question is postpartum pituitary gland necrosis is also known as dash, and the options are, the first option is Sheehan syndrome, second option is Asperger syndrome, the third option is blue baby syndrome, and the final option is HELP syndrome. So which is known as the postpartum pituitary necrosis. Simple question, direct question, and the answer for this question is option number A, that is the Sheehan syndrome. Postpartum pituitary gland necrosis is otherwise known as Sheehan syndrome, and we will see the explanation. So what is the Sheehan syndrome? It is also known as the postpartum pituitary gland necrosis. Is hypopituitarism, that is a decreased functioning of the pituitary gland, which is caused by ischemic necrosis, which is due to the blood loss and hypovolemic shock during and after childbirth. So if the patient is having any atonic PPH or any sort of bleeding and any sort of blood loss, there are chances for the ischemic necrosis, and it can result in the decreased functioning of the pituitary glands and can result in the Sheehan syndrome, otherwise known as the postpartum pituitary gland necrosis. Okay, so you can expect application level questions also from this area. Like you may get questions like the woman was admitted with severe blood loss and developed some hypopituitary features. So what is the diagnosis? Like that also questions can come. Okay, so that is Sheehan syndrome postpartum, that you have to remember. Okay, now we will other options were there that we will be explaining now. So what is a Asperger syndrome? Asperger syndrome is the it was a name which was given for the neurodevelopmental disorder having been merged into the autism spectrum disorders. Okay, Asperger syndrome, it is a name for a neurodevelopment disorder which is now included in the ASD, that is autism spectrum disorders. Okay, then what is a blue baby syndrome? Blue baby syndrome is referring to the conditions that can cause cyanosis, blue cyanosis, or blueness of the skin in babies as a result of low oxygen levels in the blood. So that is a blue baby syndrome. And one more was the HELP syndrome. So what is a HELP syndrome? It is a complication of the pregnancy, and the acronym stands for H for hemolysis, EL for the elevated liver enzymes, and LP, last LP stands for the low platelet count. Okay, so that is a HELP syndrome. Okay, so I think with that we are coming to the end of that question. I think you are getting information regarding some symptoms. Okay, so now we will move on to another 9th question, important question from the psychiatric emergency. Question is, which among the following is not a psychiatric emergency? So not a psychiatric emergency. So the options are option number A, suicide or deliberate self-harm or DSH, then option number B, stupor, option number C, mania, and option number D, withdrawal symptoms associated with any drug or alcoholic addictions. So among these, which is not a psychiatric emergency? So what is the answer? Suicide, stupor, mania, withdrawal symptoms. So it's a very easy question, no? Very easy question, and the answer for this question is option number C, that is mania. Okay, so you should understand about the psychiatric emergencies and which all conditions are coming under the psychiatric emergencies. Okay, so symptoms and conditions that is behind the psychiatric emergencies may include attempted suicide, then substance dependence, okay, or alcohol intoxication, acute depression, because acute depression can lead to suicide, then presence of the delusions, then violence, panic attacks, and significant or rapid changes in the behavior, and stupor. Okay, so these conditions are considered to be as a psychiatric emergency, and it has to be intervened in an emergency basis. Okay, so that's all regarding that question from psychiatric emergency. Now we will move on to the 10th question, and the question is, the purpose of triage systems is to. So what is the purpose of triage system? So you know what is triage and all, and we did a video before regarding the triage system that you can go through later. So what is the answer for this question? Purpose of triage system, and the options are: option number A, examine the patients thoroughly; option number B, expedite the provision of health care; option number C, diagnose all life-threatening injuries; and option number D, prioritize according to the acuity of the presentation. So what is the purpose of triage system? Slightly confusing, but you can answer it very easily. So what is the answer? What is the purpose of triage? So obviously, what is the answer? Option number D, that is, we can prioritize according to the acuity of the presentation. So prioritizing is the main thing in triage system, and the need the needy will be required will be given primary care. Okay, primary care means priority care. So we know that in the civilian medicine, this is important to ensure the sickest or the most severely injured are seen first. Okay, so the sickest or more severely injured are seen first. Okay, so that's the purpose of triage. Then comes an application level question for you. It's an application level question, and the question is: a 23-year-old woman presents with a history of lower abdominal pain, abnormal vaginal discharge, dyspareunia, fever, nausea, and vomiting for 5 days. The most likely diagnosis is. Okay, so it's an application level question. So the key points in this question are: history of lower abdominal pain is there, then abnormal vaginal discharge is there, dyspareunia. So what is dyspareunia? Painful intercourse, then fever, nausea, vomiting for the last 5 days. So what is the most likely diagnosis? So the options for your first option is acute appendicitis. Option number B, ruptured ovarian cyst. Option number C, acute pyelonephritis. And the final option is pelvic inflammatory disease. So the presentation is of which disease? So that's a simple way of explanation. This question. So what is the answer? So just think about the clinical manifestations and you can answer this question very easily. So the answer for this question is option number D, that is PID, or the pelvic inflammatory disease. So the symptoms are lower abdominal pain, abnormal vaginal discharges, dyspareunia, fever, nausea, and vomiting. So we will differentiate how we will diagnose each thing that I'll be explaining here. So you know that the pelvic inflammatory disease, or the PID, is an infection of one or more of the upper reproductive organs, including the uterus, fallopian tubes, and the ovaries. Okay, and the signs and symptoms already I have explained in the question itself. So this is the pelvic inflammatory disease. So how we can omit the other options? So that ovarian cyst rupture was the another option. So how ovarian cyst ruptures can present? So ovarian accidents are not commonly associated with fever and discharge. So there will not be fever and discharge. And other option was the pyelonephritis and appendicitis. So in this, it can cause the fever. It can cause fever, nausea, vomiting, and abdominal pain will be there. It would be unlikely that vaginal discharge will be there. And dyspareunia is uncommon in either of these cases. Okay, so with this way also you can omit these options and you can find out the answer. Pyelonephritis, appendicitis, all these things, there will not be any vaginal discharges or dyspareunia. And ovarian accidents, there will not be any fever and discharge, but all these things can be present in pelvic inflammatory disease. Okay, so like that also you can come to the answer for this question. Okay, so I think that question also was interesting. Now we will move on to the 12th question in our series, and this is regarding an enema which can be given in the emergency settings. So which question is, which is a potential side effect of fleet enema? So the question is, which is a potential side effect of fleet enema? So first of all, you should understand what is a fleet enema and what this enema contains, and you can answer this question very easily. And the options are option number A, hypophosphatemia, option number B, melanosis coli, option number C, hypercalcemia, and option number D, hyponatremia. So what is the answer? So which is a potential side effect of fleet enema? Hypophosphatemia, melanosis coli, hypercalcemia, hyponatremia. So what is the answer? The answer for this question is melanosis coli. So what is fleet enema and what is melanosis coli, that we will be explaining in the explanation session. So fleet enema contains sodium phosphates. Okay, the sodium phosphate, it belongs to a class of medication called laxatives. So obviously this medication is used to provide relief for the occasional constipation or to cleanse the bowels in preparation for a number of procedures such as colonoscopy. Okay, so you should understand this fleet enema contains the sodium phosphate, and sodium phosphate belongs to laxatives. Okay, so that is the purpose of the fleet enema. So what will happen if you are giving a fleet enema for a patient? So the complication is called as a melanosis coli. So what is melanosis coli? It is a medical condition which is caused by the release of a pigment molecule called lipofuscin into the mucous membranes of the large intestine, which can be caused by the chronic laxative use. Okay, so melanosis coli, it is a medical condition as a result of the release of a pigment called lipofuscin because of chronic laxative use. Okay, so what other problems this fleet can develop? This fleet enema can cause hypocalcemia, hyperphosphatemia, because as a sodium phosphate is there, and hypernatremia, and obviously acidosis also can result from fleet enema. So the use of fleet enema is limited in our settings. Okay, so just for your information, I have included this question in this session. So now we will move on to the 13th question in our series. And this is another gastro emergency, and the question is, which type of hernia has the lowest rate of incarceration or obstruction? Okay, so the question is, which type of hernia has the lowest rate of incarceration or obstruction? So the options for you are option number A, umbilical hernia, option number B, hiatal hernia, option number C, obturator hernia, and option number D, femoral hernia. So what is the answer? Which type of hernia has the lowest rate of incarceration or obstruction? So obviously the answer is option number A, umbilical hernia. Umbilical hernia is the answer for this question. So we will have the explanation. So we know that hernias with lower risk of obstructions are inguinal hernia, umbilical hernia, and incisional hernia. So these hernias will be having very low risk for obstruction and complications. Then which are the high risk hernias? Femoral hernia is considered to be as the high risk hernia. And another point is, what is the obturator hernia? Obturator hernias are very high risk of the bowel obstruction and perforation. Okay, so you can categorize the hernias according to this, like the lower risk hernias are inguinal, umbilical, and incisional. Femoral hernias are considered to be high risk hernias, but very high risk hernias are obturator hernias. Okay, so that's all regarding that question. Then you should understand what is an obturator hernia. What is obturator hernia? Obturator hernia occurs when there is protrusion of intra-abdominal contents through the obturator foramen in the pelvis. Okay, so you know that the obturator foramen and all, I am not going in detail about that. You can refer it later. So obturator hernia occurs when the contents of the intra-abdomen are protruding through the obturator foramen in the pelvis. Okay, so that is obturator hernia, which stands the very highest risk for the protrusion, for the obstruction and incarceration. Okay, so next, what was the hiatal hernia? Hiatal hernia occurs when weakened muscle tissues allow the stomach to bulge up through the diaphragm. That is hiatal hernia. Okay, so that's all regarding that question. Now we will move on to the second last question in this series, a very important question, and the question is, what is the key factor which distinguishes decompensated shock from compensated shock? So the question is regarding the shock, and what is the key factor which distinguishes decompensated shock from the compensated shock? So you should understand the pathophysiology of the shock, and you can answer this question very easily. So the options for you are, first one is tachycardia, option number B, tachypnea, option number C, hypotension, and option number D, vasoconstriction. So what is the answer? Which is the key factor which distinguishes between compensated and decompensated shock? Tachycardia, tachypnea, hypotension, vasoconstriction. So what is the answer? So the key factor is option number C, that is hypotension. BP is the compensating factor. So we will have a small explanation. So what do you mean by compensated and uncompensated shock? Okay, so in compensated shock, it is a category of the shock that occurs early while the body is still able to compensate for a shortfall in one or more of the three areas of perfusion. Okay, so the perfusion will be pakka, and that time the body will be compensating. One or the other way they can compensate and they can maintain the perfusion. Okay, so that is known as a compensated shock. Then in uncompensated shock, what is happening is it is a category of the shock that occurs when the compensatory mechanism fail and the patient's condition start deteriorating. So when the compensation fails, then the patient will be moving on to the more complicated stage, that is the uncompensated shock, and the patient condition can deteriorate. So the question was regarding the key factor. What is the thing that compensates for this perfusion? So that is the BP. So we know that hypotension, it reflects the difference between compensated and decompensated or uncompensated shock, and organ perfusion deteriorates when compensatory mechanisms fail to maintain the normal BP. Okay, so whenever there is a fall in the BP, there is a hypotension, that indicates that the compensation has finished, the compensation has failed, and the patient is moving into the more complicated uncompensated or the decompensated stage of the shock. Okay, and then the organ perfusion will deteriorate and the patient will go into major complications. Okay, so that is a question. Now we will move on to the next question in our series, that is the 15th question. So this is the second last question. So the question is, which of the following interventions does not form part of the emergency management of anaphylaxis? So anaphylaxis cases we can expect in the emergency department. So the question is, which of the following interventions does not form the part of emergency management of anaphylaxis? So the options for you are option number A, IV antibiotics, option number B, IM adrenaline, option number C, IV fluids, and option number D, IV antihistamines. So which is not coming in the management of anaphylaxis? That is a simple way of this question. So what is the answer? IV antibiotics, IM adrenaline, IV fluids, IV antihistamine. So the answer is option number A, that is IV antibiotics. So you know that IV antibiotics itself can cause anaphylactic reactions, okay, for patients with sensitivity towards certain antibiotics. Okay, so IV antibiotics do not form the part of the management of anaphylaxis, although they may be responsible for causing it. So the other options are important in managing the anaphylaxis in the emergency department. Okay, so now we will move on to the very last question in this series, and the question is, which of the following is the initial analgesic of choice in renal colic? So in the emergency department you can expect patients with renal calculi. So which is the initial analgesic of choice in renal calculi? So the options for you are option number A, IV opiates, option number B, oral paracetamol, option number C, rectal NSAID, and option number D, lidocaine. So what is the answer for this question? Initial analgesic of choice in renal. So the answer for this question is option number C, that is a rectal NSAIDs. Okay, so a rectal NSAID such as the diclofenac is the initial analgesic of choice in renal colic, and it tends to be very effective also. Okay, so the other options what I have given are also can be used for the pain management, but rectal NSAIDs can be used first, okay, as an initial manager. Okay, so with that we are coming to the end of this session. So in this session we have explained about the 16 very important questions which can be asked for any interviews or related to the ICU care. So I hope you understand all these questions, and thank you for watching the video till the end. And I request everyone who are watching this video to share about this platform to your nursing friends and kindly make use of it. So once again, thank you. So see you soon with another video very shortly. So winding up, thank you.